Now I want to bring up Dr. Keith Smith, the Surgery Center of Oklahoma, to give his entrepreneurship story, entrepreneurial journey. He gave a great talk at the AAPS. Was it last fall, maybe? That it's probably a talk like I've never heard before, especially at a medical conference. It was a hybrid of economics and medicine, and it was great. So I want him to sort of recap that a little bit and give you a little bit more detail about his entrepreneurial journey, and then we'll bring Dr. Dale back up for them to have some Q&A and just some good conversation. Thanks.
Well, hello. Thank you all for coming. I think Dr. Dale's a hard act to follow, but I think Dr. Lantier and I are both thinking the same thing. We need to bring him up to deal with the regulators for us. We've had a little bit different relationship with the regulators here in Oklahoma, and I'm going to try to see if I can follow your lead and decrease the temperature of the conversation, to quote you. James talking about a talk that I gave to the Association of American Physicians and Surgeons a while back, where I talked about not just the need, but the urgent need for entrepreneurialism in the physician community in particular, and why physicians were naturally disinclined to be entrepreneurial, and how to think through that and how to overcome it. My main point, I think, in that talk was for physicians to acknowledge that we tend to bring the same aversion to risk in our business practices as we do when we deal with patients. So physicians should properly mitigate risk for the patients when they talk to them about the medical care that is going to be delivered and when they deliver that care. But that same aversion to risk is not appropriate when you're actually trying to figure out how do I conduct this practice? How do I have conversations with patients about money? We are taught in medical school primarily by academicians whose attitude is they're employed. The vast majority of them are employed, but their attitude also is, well, we just practice medicine. We're on this very high level, and we don't ever want to think and we also do not think it is appropriate to have a conversation with a patient about money. And so that is an obvious invitation for the situation that Dr. Dale has described, where the physician and the patient's relationship is not just contaminated, but I would agree with you, is destroyed when the third party that is actually going to assume payment for the services enters the exam room, enters the surgery center. I think that the role of physicians has to be an entrepreneurial one. I think that physicians who are leaving medical school now that are entering employment agreements with the hospitals that are hiring them like mad are really abandoning their patients by avoiding this entrepreneurial role. Everybody in this room that's a physician works for themselves. Nobody in here is employed. And that means that decisions were made, resources were combined under conditions of uncertainty, and that risk has a reward, and it also is very punishing for someone who is not able to pull that off. I have thought for a long time that the best way to measure quality was to just start with the physicians who will say, here is what I do and here is the price attached to it. I think that you cannot know, as John Harvey said in his talk yesterday, you cannot know quality unless you know price. So there are many companies that are out there trying to put some quality stamp on physicians or hospitals or surgery centers, but without the knowledge of the price, it's it's impossible, I would argue, to and agree with John Harvey's comment yesterday. It's impossible to know quality. When you think through that, you realize there's very little pricing available. There's more and more pricing available for consumers to see thanks to this organization, but there still predominantly is not much pricing available for people to see. So if you follow that logic, you realize there's really not much quality for people to see. Once we have pricing that is visible, then I think that there will be this really dog-eat-dog competition that is so sorely lacking and that is needed. And then we'll see some boldness, and we'll see more entrepreneurs emerge in this industry. I think that physicians have to acknowledge their psychological impairment to be entrepreneurs. I think that they have to learn how to talk to patients about money. And to quote my partner, Chris Paskowski, you, as a physician, you cannot claim to be a patient advocate if you are their financial adversary. And for physicians to say, I just practice medicine and I don't deal with any of the money stuff, is to abandon them really to the wolves that are in this industry, all of whom are enabled by government at all levels. I think that to look to government to help achieve what we all are hoping for, more liberty and more entrepreneurial activity in this industry, is a mistake. I've argued for a long time that the only good public policy is that which repeals prior public policy, and that's the only way that you can truly measure progress. Entrepreneurs and entrepreneurialism, I think, is innate. It is in all of us. It is a natural course of things until it meets regulators, until it meets regulations. Dr. Per Byland at Oklahoma State University, a great Austrian economist, refers to regulations as choice restrictions. And I would like to see the word regulations removed from our lexicon, and we should always refer to them as choice restrictions. Without those choice restrictions, the entrepreneurs are not nearly as hamstrung as they'd otherwise be. Dr. Rickner, who you're going to hear from in a little bit, has met with many choice restrictions and regulations, as have Dr. Lantier and I at the Surgery Center of Oklahoma. And I want to make clear that while there are individual entrepreneurs out there in the physician community, many of the efforts that you see, including that at Surgery Center of Oklahoma, is really more of a team effort. There are actually, I would call the Surgery Center of Oklahoma an entrepreneurial firm, not necessarily just the vision of one person. And I think all through the years, there have been many ideas that were floated at Surgery Center of Oklahoma, for instance, that it really took two heads, Steve and I both together, to kind of weed our way through even the vision of the surgery center, what it should look like, how it should operate, what was our mission. Some of that came from me, some of that came from Steve, some of that, I would argue, didn't come from either one of us, but sort of came from us together. So I think it's much easier for physician entrepreneurs, particularly given their psychological disadvantage, to gang together and to bounce ideas off of each other. And Kyle, I'd be interested during your remarks to know the extent to which you and Dr. Lockwood had that same kind of experience that I know Steve and I did. My journey to thinking, I think, as an entrepreneur did not really, I don't think, begin until we actually opened the Surgery Center of Oklahoma. I was like any other anesthesiologist. I'd done some reading about markets. I had been victimized by Medicare pricing, which taught me about how prices basically are signals. There's nothing personal about them. When a bureaucrat assigned $78 to me as the fee I should receive as an anesthesiologist for a total knee, that I began to realize was not personal. That was a marketplace signal, and it really wasn't a true marketplace because this pricing was imposed on me. And I've learned that true pricing emerges from a competitive market. It's never imposed. Whenever some bureaucrat imposes pricing, it's always wrong. It's either too high or too low, and it should change. It should change over time. If prices are too high, and you pay a certain medical specialty far more than you should, you're going to get a whole lot of that service. If you underpay for a procedure, price controls cause shortages. So $78 for the anesthesia part of the service for a knee replacement seemed low to me, but I'd read enough about economics, and thanks to the Austrian school, understood that these prices were they were signal carriers, and I needed to respond to that signal, I felt like, in a rational and ethical way. And rather than resent the patient that was in front of me because I felt so grossly underpaid for the service that I was providing, I decided that I needed to send a rational message back of my own. And rather than not provide the service at all, I decided to just not receive the payments. So I seceded, basically, and I decided I would not grant Medicare the credibility that I suppose they thought they were due, and I stopped accepting federal payments. I found this very liberating. At the time, it was the most liberating act of my practice because they then had no leverage over me. Every 2 or 3 weeks, anesthesiologists all over the United States would receive a Medicare bulletin that informed them what their new maximum allowable charge was. And I remember when I was accepting Medicare money, just this panicky feeling that, wow, I'm glad I came to see my mailbox at work today so I know what I'm worth, because to charge an amount beyond that maximum allowable charge had severe penalties, and physicians who do that are treated like criminals, and some people go to jail for that. So to not have to check my mailbox every 2 to 3 weeks to find out now what am I worth, I found that very liberating. So I just provided services to Medicare beneficiaries free of charge. I told them I was not going to be filing a claim. If any of them wanted to pay me, that was fine, but I was not going to file a claim. I was just not going to participate and grant credibility to a system that I thought was insane. So, by the way, the last 6-hour open heart surgery for which I provided anesthesia services, I was paid $278. So just to give you an idea, the insanity of this imposed pricing. I believed it had a purpose, though. I don't believe it's appropriate to assign ignorance to bureaucrats. I think that you assign them evil. And if they just turned out to be stupid, then I think that's a gift to them. But we shouldn't start there. Our default should be that all people who believe they have the knowledge to impose something as like pricing on an industry, they need to first be considered evil and then do their best to prove their way out from under that indictment. At $278, though, for an open heart, I think everybody in here, I mean, who wouldn't agree that that's just ridiculous? And so it wasn't personal, though. What they really wanted to see was less of the service that I was providing. They paid $78 because they did not want someone performing the service that I was performing as often as I was performing it. I don't believe it was about saving money by paying less. I believe it was to try to save money by paying so little that people would actually not provide the service. And I still think that goes on, and I think that all the carriers have followed their lead. So when I realized these prices are signals, this is not personal, I began to really understand how bizarrely sick and dysfunctional the whole system was. Simultaneously, the hospitals began to just slobber over this whole PPO HMO movement, and saw the PPOs, as one of Jay's contacts not long ago told him, as ATM machines for their hospitals. And so it was no mystery to see the hospitals begin to make giant profits at the same time that payment to the physicians who were providing the service was plummeting. So when Medicare crushed physician payments, most physician payments in about 1992, 93, the big carriers followed suit, and they began to muscle down what physicians were actually paid for the service. Physicians responded by just doing a whole lot more of what they did. They began to see more patients. They hired mid-levels. That was the explosive growth in nurse practitioners and in nurse anesthetists and PAs. They just came out of the woodwork because the only way the physicians could financially survive was to do a whole lot more of what they were doing. None of this made sense to me. It wasn't what I signed up for. I just was a big fan of the golden rule. I thought mutually beneficial exchange should operate in the industry. We watched hospitals make a lot of money. We saw our fees drop drastically. We did not feel like we were treated fairly on the financial end. We knew patients were being brutalized financially because the hospitals were buying out physician practices. And obviously that was easier when the government crushed physician payments. Then physicians were running scared, and the hospitals were able to snatch up all these practices much, much easier. And then Medicare decided they would overpay the hospitals for procedures that were done there as opposed to at independent facilities. So the hospital used all of that revenue to then buy up competitors and buy physician practices. And so the patients were completely disenfranchised. So I believe our original vision to open the center was the realization that while all of this money was being made by the hospital, none, even less of what they were making was actually going toward providing the care or the supplies that were needed to provide them care. So quality suffered as the revenue at the hospitals where Steve and I worked went up. Quality suffered, and our fees were not fair. Patients were being brutalized with balance billing, and it seemed like there was room for improvement. I think initially we thought we can do this better. I don't think it was until after we opened and we realized that we could actually survive that we could do it differently. But initially, I think our thought was we are just going to be honest with patients about what we charge and what they are going to pay when they come here. And we'll provide the highest quality care and let no surgeon work here that we would not let work on us. So very much golden rule, mutually beneficial exchange. And when we opened, it was just a very short time before we realized that we could charge a fraction of what the hospitals were charging and still be profitable. None of the insurance carriers would work with us. We found that, so we were out of network, and people had in-network deductibles and they had out-of-network deductibles. Well, very early on, we we got a pretty good handle on what are the cost of the supplies to actually provide the care that this person needs at the Surgery Center of Oklahoma. So when patients called and they said, well, I have XYZ insurance, well, we were out of network, and we would quote them a price. And what we found, even out of network, that the all-in price that we quoted patients was less than their in-network deductible and copay if they went to one of the area hospitals. So patients were paying their entire bill to us out of their pocket and saving money rather than using their insurance benefit at an in-network facility. That's how we operated until probably 2006. So we opened in 97, and we really operated that way until about 2006. This, of course, the carriers did not work with us, of course, because the hospitals didn't want them to. And the carriers didn't work with us, too, because the carriers and the hospitals have this symbiotic volume guarantee sort of relationship, and us being included was going to soil that whole thing. So we continued to see patients out of network, and the hospitals continued to lose business to us. And there were multiple attempts made at the state legislature to crush Surgery Center of Oklahoma by the regulators and the lawmakers to make us go away. They finally stumbled on a nice little formula in about 2006 where patients had to meet their in-network deductible before it accumulated on their out-of-network deductible. So somebody had a $2,500 deductible in-network. They had a $5,000 deductible out-of-network. If they had met their in-network deductible and they went out-of-network, they didn't start at $2,501. They started at zero. This is called stacking of deductibles, and there was some wording massaging that was done that allowed this, and so it became prohibitive for all of the out-of-network patients we had seen up to that point to patronize our facility. We saw our waiting room empty, and we knew we were cheaper. We knew we were better, and this vision, this original vision, kind of took over, and I thought it would be a good idea to call some of the self-funded companies that we worked with or that for whom we had provided services and ask them, what are you paying for a tonsillectomy? We'll beat it. But we already kind of knew what that price was. And so I thought, well, I should just tell them, and then they can decide if they want to buy it. And then I realized, we can put all these prices online and just show everyone and not limit the knowledge to just the people in this area. People, and we had three goals, really. One was by posting prices online, it would start a price war. For patients to be armed with the knowledge that this is what a cruciate ligament reconstruction ought to cost. That is really good information for someone, whether they have surgery at our place or not. The other goal was to make ourselves more known to all those patients that had sticker shock. And then the other thing we really wanted to accomplish was to better understand all of the scams that were at work, because at the time, all Steve knew was our waiting room is pretty empty, and we're cheaper and we're better. And in a free market, there should be a line out the door. There should be a line of buyers trying to get in here, and there weren't. So there had to be some shenanigans at work. And at the time, we really didn't understand what was operational. And I don't pretend to know what all is operational now. I think there still are many nefarious scams that go on that keep patients away from cheaper and better. I would argue all three of our goals have been achieved. People that actually have sticker shock all over the United States know that they can go to Surgery Center of Oklahoma, they can go to FMMA Shop Health, they can find pricing, and they can either travel to a facility that will honor that pricing, or they can leverage a better price using that pricing. And I would also argue that we understand the scams a little bit better. Some of them were shocking. I was shocked even looking back at how long it took for me to get it through my thick head, why the carriers really did not want to work with us, what was repricing of claims and how did people skim off claims and make money in that way. And then I think I really did begin to understand even better this mutually beneficial exchange, this golden rule, the ethics and the morality of exchanging with patients as buyers that were also consumers, and dealing honestly with proxy buyers, the third-party administrators and others, the cost-sharing ministries that we deal with, that our long-term vision, not any kind of short-term vision, was key to our success, and it has been. And I'm so optimistic because everything that we hope to accomplish with our effort has come about, except the buyers are not stepping up to buy from this assortment of services that is very reasonably priced, as aggressively as I thought they would. There is progress every day, every week that goes by. There's another self-funded company that steps up and decides they're going to do things a different way, not just try to make their plan better, but make their plan different. But there's still a remarkable number of buyers that could save incredible sums and their employees get better care that are not stepping up. There are lots of efforts that are underway to bring more of the self-funded buyers to the table, so that they can actually provide better benefits to their employees for less money. There are a lot of efforts going on. One of the ones that I am very excited about is the potential partnership, for lack of a better word, of the Free Market Medical Association with the Mises Institute. This, you heard from Hunter Hastings yesterday, this economics for business, Mises for business, however that is sold, that is very important. A lot of these concepts for mutually beneficial exchange and the methodology and thinking of entrepreneurs, all of that brought to the sick industry that we're in will further the mission and make willing buyers and willing sellers come together in a much more efficient way. So I hope this helps explain how we kind of got where we are. Excuse me. And my thinking, Tony asked me in a conversation a little while back, what was I thinking? What were we thinking when we started Surgery Center of Oklahoma? And to be honest, I think the answer to that changes over time. Even now, I wonder, what was I thinking? Steve probably wonders, what was he thinking? We are glad we did it, but the answer to that really requires some insight that only time that is under the bridge can provide. And in my mind, my decision to forge ahead, I'm still trying to figure it out. And I don't think that's an uncommon experience for anyone that's running a successful business. I think that answer changes over time. So I'll stop there. We have some time for Q&A.